Okay, welcome everyone. Thank you for those three outstanding talks on pancreatitis and pancreatic cysts. I'm happy to welcome our three experts here, Dr. Carlos Fernandez, Dr. Sunil Sheth, and Dr. David Jin. So we'll jump right in. A number of great questions here in the chat already. We'll start with Dr. Jin. When would you recommend cholecystectomy in a patient who presents with acute pancreatitis with cholelithiasis on imaging, but has never had elevated LFTs?
It's a great question. I don't think after one episode of idiopathic pancreatitis, even if they have visible gallstones, would I recommend a cholecystectomy? I think after the second one, I would. And that actually follows the most recent ACG guidelines, which came out this year. There have been some retrospective studies. There was actually a small randomized controlled trial looking at the benefits of cholecystectomy following idiopathic acute pancreatitis. There certainly is a benefit in reducing the rate of recurrent pancreatitis in patients who have undergone cholecystectomy. I think after one, I probably wouldn't, but after the second, I would.
Okay. Another management question here about aggressive hydration being the mainstay treatment for acute pancreatitis. And if you have any suggestions on the management in patients who have maybe a cardiomyopathy and may not EF of 20% and may not tolerate aggressive hydration.
Yeah. So it's no longer the mainstay, right? It's no longer should be the mainstay. And that comes from the Waterfall trial, the multi-center trial done primarily in Europe, but around the world. That was a RCT comparing moderately aggressive versus aggressive fluid resuscitation in patients with acute pancreatitis. The primary endpoint was the development of severe disease, but that study was actually terminated early because the aggressive fluid resuscitation group reached the safety endpoint, which was volume overload at a much higher rate than those undergoing moderate IV fluid resuscitation without any significant improvement in the primary outcome, development of severe disease. So moderate should be the mainstay of treatment nowadays, and certainly in patients with underlying cardiomyopathy.
Okay, great. Thank you. Dr. Sheth, so there's a question about pancreas divisum as a cause of recurrent pancreatitis, particularly in children.
That's a good question. Any undiagnosed recurrent acute pancreatitis can lead to chronic pancreatitis. Basically, there's chronic inflammation, and once the inflammation cannot be stopped, you develop chronic pancreatitis. So the etiology of the pancreatitis does not really matter. So if pancreas divisum is causing recurrent acute pancreatitis, especially in children, it can be missed for a long period of time because they don't typically undergo ERCPs and sphincterotomies. Similarly, in the community setting, there are people who have recurrent biliary pancreatitis who've never had their gallbladder taken out, and there's a small subset of these patients that go on to develop chronic pancreatitis. It's not very common because in 2024, you would diagnose this pretty quickly and prevent this from happening.
I guess a part of the question there is the relationship between pancreas divisum as a cause for.
Well, that's a very good. There's an ongoing trial, addressing sphincterotomies, and this is something where you have to see significant abnormalities. You need to see a Santorini seal. You need to see upstream dilation on a dynamic study, such as an MRCP with secretin. Most advanced endoscopists will wait for 3 or 4 attacks and until all etiological options have been exhausted before they perform sphincterotomies in these patients.
Okay, great. And there's a question here about fibrosing enteropathy as a sequela for high-dose pancreatic enzyme replacements in chronic pancreatitis.
Yeah, right. So that was an issue many, many years ago, specifically in cystic fibrosis patients. And it was thought not because of the actual enzyme, but the formulation and the preservatives that were in the enzymes. Now, these are no longer in the market, and that's not such a big concern. And we know how to dose these well now, so this is not a concern over the last 20 years.
Okay, Great. Thank you. So, Dr. Fernandez, so lots of questions about IPMNs and cysts. So, are there predictors for progression of IPMN to adenocarcinoma, such as smoking or family history, diabetes? It can be hard to get in the US or imaging for surveillance for coverage, and sometimes maybe understanding concomitant risk factors could help with getting authorization.
Yes, so there's a recent paper that shows that smoking does enhance your risk of progression. So if you are seeing a patient with an IPMN, and this is 2.5 centimeters or whatever, and you're scratching your head, and the patient happens to be a smoker, you can give them another motivation yet to stop smoking. New onset diabetes is now considered a worrisome feature, although there was controversy in the Kyoto guidelines. The data is not completely strong. But if you got a patient that you're following for an IPMN and suddenly they develop new onset diabetes, I think your antennas need to go up and you maybe want to study this more. I'm fully espouse the concept that we cannot be doing endoscopic ultrasounds repeatedly on patients on and on forever. This is an expensive procedure. It has some a low risk profile, but it's not nil. And so it is not realistic that we're going to be following this by recurrent or repeated endoscopic ultrasounds. And finally, family history is an interesting one. If you have familial pancreatic cancer, that is 2 first-degree family members with pancreatic cancer, there's no question your risk of developing pancreatic cancer is high. However, several of us have looked at this in patients with IPMN, and your risk of your IPMN becoming malignant is not higher. But if an individual happens to have 2 or 3 first-degree family members and has an IPMN, well, that patient could develop concomitant pancreatic cancer, regular pancreatic cancer elsewhere in the pancreas. So that patient needs to probably be in a surveillance protocol for familial pancreatic cancer, which is quite stringent, right? It's MRI every 6 months, alternated with endoscopic ultrasound, depending on the degree of risk, and which unfortunately is not perfect to pick up pancreatic cancer because 6 months, it may not be close enough to be able to develop what is an aggressive tumor.
Great. Actually, there's a sort of similar question to that I'll just add on here. So this is someone asking about a person who has a family history of a mother with a branch duct IPMN with high-grade dysplasia and in the 50s and a sibling with pancreas cancer in the 70s. So essentially 2 first-degree relatives that have either high-grade dysplasia or pancreatic cancer. I think you addressed that would constitute a familial pancreatic cancer syndrome. And so that individual would be eligible for the screening that you mentioned.
Yes, I think it would be eligible. You would have to stretch the criteria a little bit. There's really not any good studies showing familial aggregation for IPMNs. I mean, and now they're so common that it's probably going to be not surprising that my brother or my cousin or my uncle also has an IPMN, right? And of course, you said IPMN with high-grade dysplasia. But genetics, as best as we can tell, so far have not played a role in the progression in IPMN, but yes, in your risk of having regular pancreatic cancer.
I will just throw in there that's someone I would probably make sure did have genetic testing anyway, just to be sure.
Oh, yes, no question.
Yeah. While we're on cysts, we'll finish with these couple of other ones. So Carlos, a couple of extremes on extremes. So do you have an age at which you stop surveillance? Would you keep doing it over 80?
I think you need to use common sense and good clinical judgment. I don't think it's fair to say somebody you turn 80, we're going to stop doing this. You may have a very healthy 80-year-old who might live until his 90s, and maybe he's got an IPMN that is scratching, being worrisome, and you discuss it with the patient, right? I think having a frank discussion of what are patient preferences and factoring in comorbidities becomes key. This requires an investment of time. So this is not just an algorithm you split into the computer. Now, you're right. Some insurers may say, hey, you're after 80, it's like a colonoscopy. Should I get a colonoscopy? Well, but that's different because in the colonoscopy, if you didn't have polyps, well, there's no reason to keep on doing colonoscopies. But an IPMN, if you already have the IPMN, of course, if it's a tiny one, just stop it.
Okay, great. So Dr. Jin, someone just, if you could repeat the criteria for MPAS-1 and how to calculate that.
For the PAS score?
Yeah, the MPAT modified, I guess MPAT modified pass one. Did you talk?
I'm not sure there is a modified version of the PASS
Oh, okay.
score. There's just the original PASS score. That's a pancreatitis activity
Okay.
scoring system. That's sort of a daily measurement of overall pancreatitis activity. There's 5 weighted components to it. One is organ failure. That's the highest weighted criteria. One is SIRS. One is the severity of abdominal pain. One is the morphine equivalent dose that they're receiving. And then the last one is whether or not they're tolerating an oral diet. So I think, the actual weights, I can't recite off the top of my head right now, but they'll be in my slide deck, which I think you have access to.
All right. Yeah, that you should. Everyone should have the full syllabus you can download on the website. So there's Dr. Jin has a question about nutrition. So does the patient need to have a decrease in abdominal pain before you start feeding? And which diet do you recommend? Liquid, regular, normal?
Yeah, they do not have to have a decrease. Go by what the patient is able to tolerate. They're telling you they're hungry, they like to try something, it's safe to do so. And it's safe to start with a solid diet. So you don't have to advance from clears to fulls to solid. Generally, we like to start with a low-fat solid diet.
Okay, great. All right, Dr. Sheth, do you typically perform an EGD to screen for gastric varices in chronic pancreatitis patients who have a splenic vein thrombosis? And do you survey intervene if you find non-bleeding varices?
No, so the question is you end up doing a one-time endoscopy once your CT scan would suggest that there are gastric varices and you take a look. But the second thing is most of these patients can develop collaterals and they decompress the left-sided portal hypertension. These rarely bleed unless there's a pseudoaneurysm, which is more a function of acute pancreatitis and necrosis. These tend not to bleed, and we don't typically anticoagulate these patients.
Okay, great. Great. So Carlos, a couple quick ones here. So do you routinely ever check CA19-9s when you survey patients?
I do. And an elevated C99 is a worrisome feature, right? And an elevated C99 can also occur in concomitant pancreatic cancer. So I do. So when you see a patient for an IPMN and you order an MRI for surveillance, I routinely order a CA99. And we also order a CA. The data for that is not as robust, but as we all know, there are individuals who do not express CA. There is some data showing that CA can also be elevated in IPMNs. So you can elect to do that. I must confess, I do not know the cost of it, but a CA99 is a reasonable thing to do.
And so on the other extreme about cysts is how do you manage people who have like truly sub-centimeter, a couple 1 or 2 millimeter cysts? And are those people that you still do their follow-up in 6 months? And when that's their first time that they've had a cyst diagnosed?
Yes. So, and that constitutes an enormous number of patients, right? By epidemiological data, as many as 40% of individuals over age 50 will have a small pancreatic cyst. And this is, average size of 5 millimeters. When you meet a person for the first time, if you want to do the right thing, in 6 months, you should repeat imaging. You want to be sure that you didn't pick up something at its onset that is growing. And if in 6 months there's nothing, then you can wait 1.5 years or 2 years to do more, and maybe at 3 years, stop it if they're really small pancreatic cysts, which, by the way, we do not know are branch duct IPMN. So there's no pathology. This could be just a little, product of aging that is not really a neoplasm.
Okay, great. Dr. Jin, can smoking cause acute pancreatitis? And if someone has an idiopathic pancreatitis, would you recommend that they stop smoking?
The answer to the first question is yes. Smoking is an independent risk factor for both acute and chronic pancreatitis, independent of alcohol, independent of age or sex. And I think you probably should be counseling all of your patients to stop smoking.
Okay, great. Dr. Fernandez, so there's a question about cyst fluid analysis, and Why do you recommend cyst fluid analysis if we know the disappointingly low sensitivity of these tests for dysplasia? And when do you absolutely recommend a FNA for a pancreatic cyst?
So I think an endoscopic ultrasound with cyst fluid analysis should only be done when you have a cyst greater than 2 centimeters. I think smaller than that, the yield is very low, and you know there's always going to be a risk with this procedure. You do it, and I would say yes, the yield can be disappointingly low. Some studies suggest that it's not, that it's higher. It allows you to make a definitive diagnosis. So you think it's an IPMN, but it's not. Maybe it's a serosistatinoma, right? And you're going to be able to get that answer. And yes, we're still struggling to identify by cyst fluid analysis those cysts that are malignant, right? That have high-grade dysplasia. And I will take the opportunity to say our goal here is not to identify invasive cancer. Our goal here is to identify high-grade dysplasia. Pancreas cancer is always bad, whether it rises in IPMN or not, and you don't want to wait until it's invasive. You want to pick up high-grade dysplasia, you know, just like in a colon polyp, right? And that's still in the works. You know, there's some data from Pittsburgh and other newer tests that suggest that it can do that, but I wouldn't hold my breath too much yet. Cytology can be useful. If I have a cyst that certainly has a worrisome feature or 2 worrisome features in a high-risk patient, I want to get a biopsy that tells me, yes, there's something a little bit more concerning, right? Highly atypical cells or suspicious for malignancy, well, that pulls the trigger, and you're going to go and do a resection or discuss it at least with the patient more in earnest. Whereas if it's completely bland, it's hard to justify doing a Whipple in somebody who's got, you know, serious comorbidities.
Okay. Dr. Sheth, I wonder if you might comment on this one about what is steatopancreatitis and what's the significance of that diagnosis?
Yeah, so we've been aware of this finding for a while, what we refer to as fatty pancreas. And fat in the pancreas, now there's increasing data, mainly some good ERCP studies, that if you have underlying fat in your pancreas, and if you undergo an ERCP, and if you get post-ERCP pancreatitis, it is more severe in people who have underlying fat in the pancreas. Now, we don't have large studies, multi-center studies showing this, but there's an increasing interest that fat in the pancreas may increase the severity of pancreatitis. It doesn't cause pancreatitis by itself. And the reasons for fat in the pancreas could be metabolic syndrome, could be prior injury, could be a variety of different things.
Okay, great. So I think we've reached the end of our session. We're a little over. Thank you all for staying. I want to thank our 3 pancreatology experts and surgeons, Dr. Jin, Dr. Sheth, Dr. Fernandez, for a really amazing session. This concludes day 3. We'll see you tomorrow. We'll start again tomorrow, again at 8:30. So I will look forward to seeing you all then, and thank you again.